Welcome to the Deep Dive. Today we're plunging into a topic that literally keeps the rhythm of life going, the human heart and its incredible electrical orchestra. We've got some fascinating source material here on basic cardiac rhythms. It's a pretty comprehensive look at how our heart's electrical system works, how we monitor it, and what happens when that rhythm goes a bit sideways.
Yeah, and this isn't just for doctors or nurses. Honestly, understanding these basic concepts helps us all grasp the incredible complexity of our own bodies and, the crucial role this electrical activity plays in our health. So our mission today really is to demystify how your heart keeps its beat, give you the essential insights without, hopefully, too much information overload.
Exactly. Think of it like a backstage pass to your heart's electrical concert. So what makes this whole system tick? Let's unpack this, okay? Before we get into looking at those, wiggly lines on an ECG, we kind of need to understand where the spark for a heartbeat actually comes from. What's generating all this electricity?
Right. What's really fascinating here is how the heart actually generates its own electrical impulse. It doesn't need the brain to tell it when to beat, just how fast or slow maybe. And this impulse then triggers the muscle contraction. It all happens thanks to a specialized internal wiring system, the cardiac conduction system. So right at the very top, we have the sinus node. Think of it as the heart's natural pacemaker.
The boss.
Kind of, yeah. It's a small cluster of cells up in the right atrium, the top right chamber, and it just fires off these regular electrical signals, setting the normal rhythm for the whole heart, usually 60 to 100 times a minute. Then, as that electrical signal travels down, it hits the AV node. This one's located a bit lower down in the right atrium.
Okay.
And you can think of this one as the heart's gatekeeper. It has a few really crucial jobs. First, it deliberately slows down the electrical signal for a fraction of a second.
Puts the
Yep.
brakes on slightly.
Exactly. And that little pause gives the upper chambers, the atria, enough time to fully squeeze their blood down into the lower chambers, the ventricles, before the ventricles get the signal to contract. It's all about efficient filling. Plus, the AV node acts as a backup pacemaker if the sinus node, falters. And importantly, it filters out dangerously fast signals coming from the atria. It protects the ventricles from getting overwhelmed.
Right, so it's making sure the timing is just perfect, like a conductor pausing slightly before the big brass section comes in. What happens after the gatekeeper?
Precisely. Good analogy. So from the AV node, the impulse then speeds up again, quite dramatically actually, through the bundle of His. It's a short little bundle of fibers. And then it splits into the right and left bundle branches. These are like high-speed electrical highways, taking the signal rapidly down into each ventricle.
You're spreading it out.
Yep. And finally, we have the Purkinje fibers. Think of these as a network of really fine electrical threads that spread the impulse almost instantly throughout the entire ventricular muscle. This ensures a really synchronized, powerful contraction to pump the blood out. And these fibers, interestingly, also have their own very slow backup pacing ability, kind of a last resort if everything else fails.
Wow. Okay, so the normal pathway is sinus node kicks things off, signal flows through the atria, pauses briefly at the AV node gatekeeper, then zooms down the bundles and into the Purkinje fibers, making the ventricles contract.
You got it.
And that perfectly timed electrical spread is what creates the classic surface ECG we can actually record on the skin. So here's where it gets really interesting. How do we actually read this electrical fingerprint?
Right, the ECG. It's essentially a graphic record, a picture of all this electrical activity we just talked about. Imagine it as a unique electrical story of your heart, written out beat by beat on that grid paper. When we look at an ECG strip, there are key sort of words and phrases or waveforms and intervals that we identify. The first is usually the P wave. That's typically the first small, rounded bump you see. It tells us the upper chambers, the atria are electrically firing, depolarizing, and getting ready to contract.
Okay, the atrial activation. And after that small bump, there's usually that big spike we associate with a heartbeat, right? The main event.
Yes, exactly. That's the QRS complex. This is the main, sharp, usually tall spike. And it represents the powerful electrical firing or depolarization of the lower chambers, the ventricles, as they contract and pump blood out to the body. Its width, how long it takes from start to finish, is really important. Normally it's very quick, like less than 0.12 seconds. If it's wider than that, it can signal a problem. Maybe the electrical signal is traveling slowly through the ventricles for some reason.
Like a traffic jam down there.
Kind of, yeah. Then after that big QRS spike, you'll see the T wave. This usually looks like a broader, more rounded bump. It represents the ventricles recharging or recovering electrically, repolarizing after their contraction, getting ready for the next beat. It normally points in the same direction as the main QRS spike.
Okay.
And right between the end of the QRS and the beginning of the T wave, there's usually a flat section that's called the ST segment. Normally, it should be right on the baseline, the flat line between beats. If that ST segment is elevated or depressed, pushed up or down, that can be a really significant clue for things like myocardial infarction, a heart attack, or ischemia, lack of blood flow.
Wow, okay, so those are the main shapes on the page.
Mm-hmm.
But you mentioned intervals, too, the spaces between the shapes.
Exactly. The timing is just as important as the shapes. The PR interval is measured from the very start of that P wave to the very start of the QRS complex. It tells us the time it takes for the electrical signal to travel from the atria through that AV node gatekeeper we talked about and down to the point where the ventricles start firing.
So it includes that crucial delay at the AV node.
Precisely. If the PR interval is too long, it suggests there's an excessive delay in that conduction pathway. Then there's the QT interval. This measures the total time for the ventricles to electrically fire, depolarize, and then fully recover, repolarize. So from the start of the QRS to the end of the T wave. This interval is tricky because it naturally varies with your heart rate. It gets shorter as the heart beats faster. So we often have to calculate a corrected QT interval, or QTC, to standardize it.
Oh, okay.
And if that corrected QT interval is too long, it can be a warning sign. It means the ventricles are taking too long to recharge, which can increase the risk for certain dangerous, fast heart rhythms.
Got it. Sometimes there's a little wave after the T wave, a U wave.
Yes, the U wave. It's often not visible, but sometimes you see a small, rounded wave after the T wave. Its exact cause isn't perfectly understood, but it might relate to the final phase of ventricular recovery. It can become more prominent, sometimes quite large, with certain electrolyte imbalances, like low potassium or other conditions that prolong repolarization. And all of this, all these waves and intervals are printed on that special ECG grid paper.
Right, the graph paper background?
Yeah. Horizontally across the paper, it measures time. Each tiny small square is usually 0.04 seconds, and each larger square made of 5 small squares is 0.2 seconds. Vertically up and down, it measures the electrical voltage or strength. Each small square is 1 millimeter, representing 0.1 millivolts, and each large square is 5 millimeters, or 0.5 millivolts.
So it's like a really precise map of time and electrical power generated by the heart. It's truly like the sheet music for your heart's rhythm. But how do we actually use this to understand what's happening in real time and keep an eye on things, especially for someone who's maybe quite ill?
That's where continuous cardiac monitoring comes in. It's absolutely vital, particularly for patients who are critically ill or at risk for rhythm problems. It allows for, early identification and hopefully quick treatment of any rhythm alterations. The goals of monitoring can range quite a bit. Sometimes it's just basic heart rate tracking. Other times it's for diagnosing complex dysrhythmias or even detecting subtle signs of cardiac ischemia, that lack of blood flow we mentioned.
It's not just one size fits all. And you mentioned leads earlier. The placement matters.
Oh, absolutely. The choice of monitoring leads, which electrical viewpoints we're looking from, is really important. For example, specific lead placements, often referred to by names like V1 or V6 or sometimes MCL1, are often the best for telling the difference between certain fast rhythms with wide QRS complexes, like figuring out if it's ventricular tachycardia versus something less dangerous coming from above the ventricles.
Okay.
Another common lead 2, is often really good for clearly seeing the P waves, the atrial activity, or spotting those characteristic sawtooth waves of atrial flutter. So choosing the right lead depends on what you're specifically looking for.
So the exact placement of those sticky electrodes on the skin really matters for getting the right picture. It's not just, slapping them on anywhere.
Definitely not. Electrode placement is crucial for getting accurate information. There are standard positions. For instance, in a common 5-wire system, you typically place electrodes on the shoulders to represent the arms and lower on the torso or hips for the legs to minimize muscle artifact from movement. Then, specific chest lead positions, like V1 in the 4th intercostal space just to the right of the sternum, give us those valuable viewpoints we just discussed.
And keeping the skin clean and stuff matters too, right?
Hugely. Good skin preparation is key. You need to clean the skin, make sure it's dry, maybe even gently abrade it slightly to ensure good electrical contact. And changing the electrodes regularly, usually daily, helps prevent skin irritation and ensures the signal stays clear and reliable, minimizing artifact or noise.
Okay, so we got the monitor set up correctly, good leads, good skin prep. How do we quickly figure out the heart rate from looking at these strips, maybe without reaching for a calculator every time?
Yeah, there are some good shortcuts for heart rate determination, especially when the rhythm is regular, meaning the beats are evenly spaced. One quick way is the large box method. Find an R wave, the peak of the QRS, that lands on a heavy line on the grid paper. Then count the number of large squares until the next R wave. Divide 300 by that number.
Okay, so if there are, say, 4 large squares between R waves.
Then the rate is 300 divided by 4, which is 75 beats per minute. Simple as that. If it was 3 large squares, it'd be 100. 5 squares, 60. It's a quick estimate.
Nice. What about for faster rates or more precision?
For more precision, you can count the number of small squares between 2 R waves and divide 1500 by that number. So if there are 20 small squares, 1500 divided by 20 is 75 beats per minute.
Okay, that makes sense. But what if the rhythm is irregular, like in atrial fibrillation? Those tricks won't work then, right?
Exactly. For irregular rhythms, those methods aren't reliable because the distance between beats varies. So the standard approach is to get a 6-second strip of the ECG. Most ECG paper has markings at the top indicating 3-second or 6-second intervals. You count the number of QRS complexes within that 6-second strip and simply multiply that number by 10. That gives you the average ventricular rate per minute.
Ah, clever. So count the beats in 6 seconds times 10 gives you beats per minute, and you can do the same for the atrial rate using P waves.
Precisely. If you can clearly see the P waves, you use the exact same methods counting boxes for regular atrial rhythms or the 6-second strip method for irregular ones just using the P waves instead of the R waves.
Okay, so now we know how to set up the monitoring, read the basic waveforms, and count the beats. But just counting isn't enough, right? We need to interpret the whole symphony. What's the best way to approach that systematically?
You're absolutely right. Correctly determining the cardiac rhythm requires a really systematic evaluation. It's almost like being a detective, following a checklist to make sure you don't miss any critical clues. We generally use about 6 key steps for rhythm interpretation. 1, calculate the atrial rate using the P waves. 2, calculate the ventricular rate using the QRS complexes.
Okay, rates first.
Yep. 3, determine the regularity and look closely at the shape of the P waves. Are they all the same? Is there one before every QRS? 4, determine the regularity, shape, and importantly, the width of the QRS complexes. Are they narrow or wide? Consistent.
Right, checking consistency and timing.
Exactly. 5, measure the PR interval. Is it constant? Is it within the normal range? 0.12 to 0.20 seconds. And finally, 6, put all those pieces together to interpret the dysrhythmia. What does this pattern tell us? Following these steps every time helps ensure accuracy and prevents jumping to conclusions.
That makes a lot of sense. A structured approach.
And this systematic approach helps us identify what we call a dysrhythmia, which, by the way, raises an interesting point. You hear dysrhythmia and arrhythmia used. Are they different?
Good question, and maybe a surprising fact for some listeners. Dysrhythmia and arrhythmia are actually synonymous. They both just refer to any cardiac rhythm that isn't that perfect normal sinus rhythm we talked about earlier.
Right. And understanding where an abnormal rhythm originates, which part of the conduction system is causing the issue, often tells you a lot about its characteristics and, more importantly, its potential impact on your health. Our source material actually groups them this way, which is really helpful.
Okay, perfect.
Uh-huh.
So let's walk through them based on their origin, starting right at the top with rhythms originating in our natural pacemaker, the sinus node itself.
Right. So first, the baseline, the gold standard. Normal sinus rhythm. This is what we ideally want to see. The rate is steady. Between 60 and 100 beats per minute, it's regular. There's a normal-looking P wave right before every single QRS complex, and the PR and QRS intervals are within normal limits. Everything's working as it should.
The heart's happy place.
Pretty much. Then there's sinus bradycardia. Brady means slow. So this simply means the heart rate is originating from the sinus node. It's regular, but it's slower than 60 beats per minute. Now, this can be completely normal, even healthy for some people think well-trained athletes, or just during deep sleep. But why it matters is if that slow rate causes symptoms, things like dizziness, confusion, fatigue, low blood pressure.
So it's about how the person feels with that rate.
Exactly. It's only treated if it's symptomatic. The first-line treatment is often a medication called atropine to speed the heart up. If that doesn't work or it's severe, temporary or even permanent pacing might be needed.
So if you're feeling totally fine and happen to notice your resting heart rate is, say, 55, don't necessarily panic. But if you're feeling faint or unwell with a slow rate, that's different.
Got it. What about the other end of the spectrum, when the sinus node is just firing too fast?
That's sinus tachycardia. Tachy means fast. So here, the rate is faster than 100 beats per minute, but it's still originating from the sinus node and is usually regular. Now, again, this is a perfectly normal response to things like exercise, stress, excitement, pain, fever. Your body needs more oxygen, so the heart speeds up.
However, here's where it gets crucial. If your heart is persistently racing, over 100 beats per minute while you're at rest, it's often a sign that something else is going on. An underlying problem like dehydration, anemia, counterintuitive. That when your heart beats too fast for too long, it actually becomes less efficient. It has less time between beats to fill with blood, that's diastolic time, so the amount pumped with each beat, stroke volume, can decrease. And the heart muscle itself gets less time to receive its own blood supply through the coronary arteries.
Wow, so faster isn't always better?
Definitely not, especially sustained fast rates at rest.
Yeah.
So the treatment for sinus tachycardia always focuses on finding and treating that underlying cause. Address the fever, manage the pain, correct the anemia, etc.
Okay, what about sinus dysrhythmia? That sounds a bit more worrying.
It sounds complex, but it's usually not worrying at all. Sinus dysrhythmia is simply an irregular rhythm originating from the sinus node, where the heart rate subtly speeds up when you breathe in and slows down when you breathe out. The overall average rate is still usually within that normal 60 to 100 range.
Ah, so it varies with breathing.
Exactly. It's very common, especially in children and young adults, and it's generally considered completely benign. Rarely, if ever, needs any treatment.
Okay, that's reassuring. And what if the sinus node just decides to take a little break, like skips a beat entirely?
That's what we call sinus arrest or sinus pause. Here, the sinus node just fails to fire for one or more beats. So on the ECG, you'll see a pause where a P wave and QRS complex should have been. It looks like a skipped beat or a longer gap. Causes can include certain medications, problems with blood flow to the sinus node itself, like during a heart attack, or just excessive stimulation of the vagus nerve, which slows the heart. Why it matters is if these pauses are frequent or long enough to cause symptoms lightheadedness, fainting spells. If the pauses are significant, it indicates a potentially serious problem with the heart's primary pacemaker. Treatment aims at the underlying cause, but if the person is symptomatic, atropine or temporary pacing might be needed.
All right, that covers the sinus node. Let's move down the electrical pathway now and look at rhythms that originate in the atria, the heart's upper chambers, but not from the sinus node itself.
Right. So sometimes an irritable spot or focus somewhere else in the atrial muscle decides to fire off an electrical impulse before the sinus node is due to fire. This creates an early beat. We call these premature atrial complexes, or PACs. On the ECG, you'll see a P wave that looks a bit different from the normal sinus P waves, and it comes earlier than expected, usually followed by a normal-looking QRS complex.
Like an extra beat jumping in line.
Pretty much. People often feel these as palpitations or stipped beats. They're usually harmless, often triggered by common things like caffeine, alcohol stress, fatigue, or electrolyte imbalances. Generally, no treatment is needed for occasional PACs. However, if they become very frequent, they can sometimes precede or trigger more significant atrial dysrhythmias, like atrial fibrillation. So, while usually benign, very frequent PACs might warrant a bit more attention.
Okay. What about rhythms where the pacemaker seems to be jumping around different spots in the atria?
Ah, yes. If the heart's pacemaker site seems to be shifting randomly between the sinus node and various other spots in the atria, causing P waves that have at least 3 different shapes within the same ECG strip, we have a couple of possibilities depending on the rate. If the overall heart rate is within the normal range, 60 to 100 BPM, and you see those varying P wave shapes, it's called wandering atrial pacemaker, WAP. This is usually benign and often doesn't require specific treatment.
Okay, just a bit indecisive.
Kind of. But if that same pattern, at least 3 different P wave shapes, irregular rhythm occurs with a heart rate faster than 100 beats per minute, it becomes multifocal atrial tachycardia, MAT. MAT is often associated with significant underlying illness, especially severe lung disease like COPD or heart failure, often related to hypoxia or electrolyte problems. So the treatment for MAT focuses heavily on addressing that underlying condition, improving oxygenation, correcting electrolytes. Sometimes medications like beta blockers might be used consciously for rate control.
So, WP is usually okay, but NK signals a bigger problem elsewhere. Got it. What about a sustained rapid rhythm coming from just one spot in the atria, but not the sinus node?
Right. That brings us to atrial tachycardia, AT, sometimes called ectopic atrial tachycardia. Here, a single irritable focus in the atria takes over and fires rapidly, typically between 120 and 250 beats per minute. It's usually a regular rhythm. Because it's so fast, the P waves might be hidden within the preceding T wave, making them hard to see, or they might look different from the normal sinus P waves. Why this matters? These rapid rates can cause symptoms like palpitations, shortness of breath, dizziness. Sometimes, especially if the rate is extremely fast, the AV node might block some of the impulses, leading to AT with block, which can sometimes be a sign of digitalis toxicity. Treatment involves trying to eliminate the cause if possible, like stopping a triggering medication, controlling the heart rate with drugs like beta blockers or calcium channel blockers, or trying to convert the rhythm back to sinus using drugs or electrical cardioversion. For recurrent problematic AT, a procedure called catheter ablation, where they neutralize that irritable spot, is often very effective and is actually a Class I recommendation for prevention.
Ablation seems like a common theme for fixing these faster rhythms.
It really is. It offers a potential cure for many of these tachycardias originating from specific spots or circuits. Now, a very distinct and important atrial rhythm is atrial flutter. Here, instead of a single spot firing, the electrical impulse gets caught in a large organized loop or reentry circuit, usually in the right atrium. This causes the atria to depolarize very rapidly, often around 250 to 350 beats per minute, frequently right around 300. This rapid, regular atrial activity creates a very classic sawtooth pattern on the ECG instead of distinct P waves. You see these flutter waves or F waves?
Tooth waves, okay. Why is flutter such a big deal?
It matters for a couple of critical reasons. First, while the AV node usually blocks many of these extremely fast atrial impulses, like maybe only letting every second or fourth beat through, leading to a ventricular rate of 150 or 75, the ventricular rate can still be quite fast, leading to symptoms from decreased cardiac output. But perhaps more importantly, just like in AF, because the atria are fluttering instead of contracting effectively, blood can become stagnant, especially in that little pouch called the left atrial appendage. This dramatically increases the risk of forming mural thrombi or blood clots within the atria.
The clot risk again.
Exactly. And if one of these clots breaks loose, it can travel through the bloodstream and cause a systemic embolism, most devastatingly a stroke if it goes to the brain, or a pulmonary embolism if it originates in the right atrium. So treatment priorities for atrial flutter are, first, control the ventricular rate using those beta blockers or calcium channel blockers again. Second, convert the rhythm back to sinus, often with cardioversion or drugs. Third, and crucially, prevent clots with anticoagulation, blood thinners. And again, catheter ablation is highly effective for atrial flutter, often considered first-line therapy because it can cure the rhythm by interrupting that reentry circuit.
Okay, flutter sounds organized but dangerous because of clots. And then there's the big one, the most common irregular rhythm, the one we hear about constantly.
Yes, atrial fibrillation, or AF as it's often called. This is the most common sustained cardiac dysrhythmia encountered in clinical practice. And unlike the organized flutter, AF is essentially electrical chaos in the atria. Multiple random spots in the atria are firing off chaotically and rapidly, causing the atrial muscle to just quiver or fibrillate instead of contracting in an organized way.
Just electrical anarchy up there.
Pretty much. On the ECG, you see no discernible P waves at all. Instead, the baseline looks chaotic or wavy. Those are called fibrillatory waves or F waves. And because the AV node is getting bombarded with hundreds of these chaotic impulses per minute, it lets them through irregularly. So the hallmark of AF is a ventricular response, the QRS complexes, that is irregularly irregular. There's no pattern to the randomness. AF can be classified in different ways. Paroxysmal means it comes and goes on its own, usually lasting less than 7 days. Persistent means it lasts longer than 7 days and needs intervention to stop. Long-standing persistent is over 12 months, and permanent AF is when the patient and doctor decide not to try to restore normal rhythm anymore.
Okay, different types. But why is AF such a major health concern? What are the real dangers?
The adverse consequences of AF are absolutely crucial for listeners to understand. There are 3 main ones. First, decreased cardiac output. Because the atria are just quivering, you lose that coordinated atrial kick, that final squeeze that tops off the ventricles before they pump. This loss alone can reduce cardiac output by up to 20–30%, leading to fatigue or shortness of breath. Plus, if the ventricular rate is very fast and irregular, the ventricles don't have enough time to fill properly, further reducing output.
Okay, less efficient pump.
Second, tachycardia-induced cardiomyopathy. If the ventricles are allowed to beat too rapidly, say consistently over 100, 110 BPM, for weeks or months due to uncontrolled AF, the heart muscle itself can weaken and enlarge, leading to a form of heart failure. And third, arguably the most devastating consequence, thromboembolism. Just like in flutter, but even more so because the chaos is greater, blood stagnates in the fibrillating atria, especially in that left atrial appendage. Clots form.
And those clots can travel.
Exactly. If a piece breaks off, it can travel anywhere, but the biggest fear is it going to the brain and causing a stroke. AF is responsible for a huge proportion of strokes, especially in older adults, and these strokes are often more severe and disabling than strokes from other causes. This thromboembolic risk is the #1 reason why recognizing and managing AF is so critical.
That's incredibly important to emphasize, the stroke risk. So preventing stroke in AF patients is clearly a massive priority. How is that managed? It sounds complex.
It is the key priority, and yes, management is complex and very individualized, but it generally focuses on 3, sometimes 4, main pillars. Pillar 1 is rate control, slowing down that rapid, irregular ventricular response to improve symptoms and prevent that tachycardia-induced cardiomyopathy. Medications like beta blockers or calcium channel blockers are the mainstays here. Pillar 2 is rhythm control, trying to restore and maintain normal sinus rhythm. This might involve electrical cardioversion, a scheduled shock, or antiarrhythmic medications like flecainide, propofenone, amiodarone, sotalol. There are many options, each with its own risks and benefits. However, studies have shown that for many patients, especially older ones, a rate control strategy is often just as good as a rhythm control strategy in terms of major outcomes, as long as the third pillar is addressed.
And the third pillar is?
Thromboembolism prevention. This is paramount. We need to assess every patient's individual stroke risk. The most common tool for this is the CHA2DS2VS score.
Okay, what goes into that score?
It's an acronym. C for congestive heart failure, H for hypertension, A2 for age 75 or older, counts for 2 points, D for diabetes, S2 for prior stroke or TIA, also 2 points, V for vascular disease like peripheral artery disease or prior heart attack, A for age 65-74, and S for sex category. Female sex gets a point, as studies show slightly higher risk.
Wow, okay, lots of factors.
Yeah, you add up the points. Generally, a score of 0 in men or 1 in women, just for being female, means low risk and anticoagulation might not be needed. A score of 1 in men or 2 in women means intermediate risk, where anticoagulation should be considered. And a score of 2 or more in men or 3 or more in women indicates high risk, and anticoagulation with blood thinners is strongly recommended unless there's a very high bleeding risk.
And what kind of blood thinners?
Historically, warfarin was the main one, but now we have the NOACs, or DOACs novel, or direct oral anticoagulants like dabigatran, rivaroxaban, apixaban, edoxaban. These are often preferred now as they're easier to manage than warfarin, with fewer interactions and no need for constant blood monitoring. But the choice depends on individual factors.
So anticoagulation is key based on that risk score. Any other strategies?
Yes. The fourth pillar, especially for rhythm control or stroke prevention, involves non-pharmacologic management. Catheter ablation, specifically pulmonary vein isolation, ablating around the areas where AF often originates, is increasingly used, especially for paroxysmal AF or when drugs fail or aren't tolerated. There are also surgical procedures like the Cox-Maze procedure, and importantly, for patients who can't take long-term anticoagulation due to bleeding risk, there are procedures to physically close off or remove the left atrial appendage, LAA, since that's where 90% of AF-related clots form. Devices can be implanted via catheter to plug the appendage, effectively.
The main source of the clots. Okay, that covers AF in detail. Now, what about those regular fast rhythms that come from above the ventricles? But maybe the exact mechanism isn't immediately obvious on the ECG.
Right, those are often grouped under the umbrella term supraventricular tachycardia, or SVT. Supraventricular just means originating above the ventricles. It's kind of a catch-all term for regular, usually narrow QRS tachycardias, where you might not clearly see P waves or be able to immediately tell if it's atrial tachycardia or something involving the AV node itself, like AV nodal reentrant tachycardia, AVNRT, or maybe involving an extra electrical pathway between the atria and ventricles, like in Wolff-Parkinson-White WPW syndrome.
So a fast, regular rhythm, probably starting upstairs.
Yeah.
But the specifics might need more investigation.
Exactly. The heart rate is usually quite fast, often 140 to 250 beats per minute, and typically very regular. P waves are often buried within the QRS or T wave. Treatment often starts with simple vagal maneuvers, things like bearing down as if having a bowel movement, Valsalva maneuver, or sometimes carotid sinus massage. done carefully by a professional.
Mhm.
These maneuvers increase vagal tone, which can slow conduction through the AV node and sometimes break the rhythm. If those don't work, the go-to medication is often adenosine. It's given IV, works very quickly to block the AV node for a few seconds, and is highly effective at terminating most SVTs that rely on the AV node. Other options include calcium channel blockers or beta blockers. For unstable patients, synchronized cardioversion is needed. And just like with AT and flutter, radiofrequency catheter ablation can often offer a permanent cure by eliminating the re-entry circuit or accessory pathway responsible.
Okay, we've covered the sinus node and the atria extensively. Let's move just a little bit lower in the heart now to the atrioventricular AV junction. That area around the AV node are electrical gatekeepers. What kinds of rhythms originate right there?
Right, these rhythms arise from the pacemaker cells located within the AV junction itself. What's often distinct about these as we look at the ECG is the relationship between the P wave and the QRS complex. Because the impulse starts in the middle, it often travels backwards retrograde into the atria and forwards into the ventricles at roughly the same time. So the P wave, if you see it, might appear right before the QRS with a very short PR interval, or it might be hidden within the QRS complex, or sometimes it even appears just after the QRS complex, and it's usually inverted because it's traveling backward.
Ah, okay, so the P wave's position and shape give you the clue it's coming from the junction.
Exactly. We can see premature junctional complexes, or PJCs. Just like PICs, these are early beats, but they originate from an irritable focus in the AV junction instead of the atria. They'll have that characteristic P wave appearance, or lack thereof, and usually a narrow QRS. The causes are similar to PACs, maybe nicotine, caffeine, stress, electrolyte issues, heart disease, sometimes digitalis. Like CACs, they are usually benign and typically don't require specific treatment unless very frequent or symptomatic.
Okay, extra beats from the junction. What about sustained rhythms originating there?
Yes, we can have junctional rhythms. These occur when the sinus node rate slows down significantly, or if the signal from the atria is blocked somehow, allowing the AV junction's inherent pacemaker, which normally beats slower, around 40-60 BPM, to take over. This is called a junctional escape rhythm. We classify these based on their rate. If the rate is between 40-60 BPM, the junction's natural rate, it's just called junctional rhythm. If something causes the junctional pacemaker to speed up a bit, between 60-100 BPM, we call it accelerated junctional rhythm. And if it goes even faster, over 100 BPM, up to maybe 250, it's junctional tachycardia.
So, slow, medium, and fast versions coming from the junction. What causes these?
A very common cause, especially for accelerated junctional rhythm or junctional tachycardia, is digitalis toxicity. It's a classic sign to look out for in patients taking that medication. Other causes can include heart surgery, inflammation, or ischemia affecting the AV node area. Treatment depends entirely on the rate and whether it's causing symptoms. If the rate is too slow, junctional escape rhythm, and causing problems, atropine might be tried, or pacing if needed. If it's too fast, junctional tachycardia, and causing issues, treatments might include beta blockers or calcium channel blockers. And crucially, if digitalis toxicity is suspected, holding or reducing the digitalis dose is essential.
Okay, that covers the junction. Now let's get into the rhythms originating in the ventricles themselves, the main pumping chambers. Okay, let's unpack this. These rhythms, the ones starting way down in the ventricles, are often considered the more dangerous ones, aren't they?
Yes, absolutely. Generally speaking, rhythms originating in the ventricles have a greater potential to be hemodynamically significant, meaning they can severely impact blood pressure and cardiac output, and some can even lead to sudden cardiac death, so they definitely command respect. Let's start with premature ventricular complexes, or PVCs. Similar to POCs, LICs, and PJCs, these are extra early beats, but they originate from an irritable focus within the ventricular muscle itself, below the AV junction and bundle branches.
Okay, an early beat from the bottom chambers. How do they look on the ECG?
They look quite different from the normal beats. Because the impulse starts in the ventricle and spreads slowly through the muscle rather than using the fast conduction highways, the resulting QRS complex is wide, usually 0.12 seconds, and often has a bizarre shape. It looks distinctly different from the patient's normal, narrower QRS complexes. Also, because the PVC originates independently, there's usually no preceding P wave associated with it, or if a P wave happens to occur around the same time, it's dissociated. Sometimes you might see a retrograde P wave after the PVC. And typically, there's a compensatory pause after the PVC before the next normal beat resumes.
Wide and bizarre QRS, no P wave before it, maybe a pause after. Got it. What causes PVCs?
Lots of things. They can be caused by hypoxia, low oxygen, myocardial ischemia or infarction, heart attack, electrolyte imbalances, especially low potassium or magnesium, stimulants like caffeine or nicotine, stress, anxiety, certain medications, structural heart disease. The list is long. They're actually very common even in people with perfectly healthy hearts.
So if someone has PVCs, is it always dangerous?
That's the key question why it matters. In individuals with otherwise normal hearts, occasional PVCs are generally considered benign and don't affect prognosis. However, in patients who do have underlying structural heart disease, like heart failure, cardiomyopathy, or significant coronary artery disease, or, especially in the setting of an acute MI, frequent or complex PVCs can be more concerning. We look for patterns like PVCs occurring very often, happening in pairs, couplets, or runs of 3 or more, non-sustained VT, having multiple different shapes, multifocal, or occurring right on the T wave of the preceding beat, the R on T phenomenon. These patterns, in the context of heart disease, may indicate an increased risk of developing sustained ventricular tachycardia or fibrillation.
So context is everything with PVCs. Healthy heart, usually okay. Diseased heart, pay closer attention. How are they treated?
Treatment is generally reserved for patients who are highly symptomatic, feeling lots of palpitations, dizziness, or if there's concern about triggering more dangerous rhythms in the setting of heart disease. First steps are usually to identify and correct any underlying cause, fix electrolytes, reduce stimulants, manage anxiety. If needed, low-dose beta blockers are often the first-line medication. Interestingly, large studies have shown that aggressively suppressing PVCs with stronger antiarrhythmic drugs in certain populations, like post-heart attack patients, does not necessarily reduce mortality and can sometimes even be harmful. So we're often cautious about trying to eliminate every single PVC. For very frequent symptomatic PVCs from a single focus, catheter ablation can be an option.
Okay, so treat the patient and the context, not just the ECG squiggle. What about rhythms where the ventricles are actually the only thing pacing the heart because the higher pacemakers have failed?
Right, those are called idioventricular rhythms. Idio meaning self or inherent. These are essentially escape rhythms originating from a pacemaker focus within the ventricles themselves when the sinus node, atria, and AV junction have all failed to initiate a beat, or the impulses are completely blocked. Because they originate in the ventricles, the QRS complexes are wide and bizarre, just like PVCs. The key difference is the rate. The inherent pacemaker rate of the ventricles is very slow, typically less than 50 beats per minute, often between 20-40. So an idioventricular rhythm, IVR, is a slow, wide QRS rhythm.
Very slow. Okay. Is that dangerous?
It indicates that the higher pacemakers aren't working, which is serious, but the IVR itself is acting as a safety net, albeit a slow one. The slow rate can certainly cause symptoms of low cardiac output. Now, sometimes this ventricular pacemaker speeds up a bit into the range of 50 to 100 beats per minute. When you have a wide QRS rhythm at this rate, originating from the ventricle, we call it accelerated idioventricular rhythm, AIVR.
So faster than expected for a ventricular escape rhythm, but not quite tachycardia yet.
Exactly. AIVR is actually quite common, especially during the period right after a heart attack when blood flow is restored to an area of the heart muscle, reperfusion. It often looks alarming because it's wide and relatively fast, but it's usually transient, often doesn't cause hemodynamic problems, and is generally considered benign in that context. For both IVR and AIVR, treatment is usually not aimed at suppressing the rhythm itself because it might be the only thing keeping the heart beating. If the rate is too slow in IVR and causing symptoms, atropine might be tried, though often ineffective for ventricular rhythms, or pacing might be necessary. AIVR usually resolves on its own and rarely requires treatment.
Okay, slow escape rhythms. Now for the really fast ones from the ventricles, ventricular tachycardia or VT.
Yes, VT. This is defined as 3 or more consecutive PVCs, or a sustained rhythm originating in the ventricles at a rate greater than 100 beats per minute. The ECG typically shows a rapid, wide QRS complex rhythm, OIR point dulves. It can be monomorphic, meaning all the QRS complexes look the same, suggesting it's coming from a single spot or circuit. Or it can be polymorphic, where the QRS complexes vary in shape and size, suggesting multiple origins or a changing circuit.
Monomorphic versus polymorphic VT. And P waves.
Usually the atria are doing their own thing, so you might see P waves marching through at a slower rate, completely dissociated from the rapid, wide QRS complexes. This is called AV dissociation, a key clue for VT. Sometimes, though, there might be retrograde conduction back to the atria.
What causes VT? It sounds serious.
It is potentially very serious. The most common underlying cause, by far, is coronary artery disease, especially in patients with a history of heart attack. Scar tissue can provide the substrate for reentry circuits. Other major causes include heart failure, cardiomyopathy, certain genetic conditions, electrolyte abnormalities, and some medications. Why it matters. VT is a medical emergency, especially if the patient is hemodynamically unstable, meaning they have symptoms like severe shortness of breath, chest pain, altered mental status, or very low blood pressure, hypotension. This indicates the heart is beating so fast and inefficiently that it can't maintain adequate circulation. Sustained VT can also degenerate into ventricular fibrillation.
So how is VT treated? And it sounds urgent.
Extremely urgent if the patient is unstable. The treatment depends critically on whether the patient has a pulse and how stable they are. If the patient has VT but is unstable with a pulse, the treatment is immediate synchronized cardioversion, that precisely timed electrical shock we discussed earlier. If the patient has VT but is pulseless, it's treated exactly like ventricular fibrillation with immediate defibrillation, unsynchronized shock, and CPR. If the patient has VT, has a pulse, and is stable, then medications can be tried first. Antiarrhythmic drugs like amiodarone or lidocaine are common choices. Long-term management for patients who have survived VT or are at high risk often involves medications, possibly catheter ablation to target the VT origin, and very commonly the implantation of an implantable cardioverter defibrillator, ICD. This device monitors the heart rhythm continuously and can automatically deliver pacing or a shock if VT or VF occurs again.
That ICD sounds like a crucial safety net. You mentioned polymorphic VT. Is there a special type of that?
Yes, there's a very specific type of polymorphic VT called torsades de pointe, which literally means twisting of the points. This occurs specifically in the setting of a prolonged QT interval, that ventricular repolarization time we talked about. On the ECG, you see polymorphic VT, where the QRS complexes look like they are twisting around the baseline. It's often triggered by medications that prolong the QT interval or by electrolyte imbalances like low potassium or magnesium. Torsades is dangerous because it can also degenerate into VF. Treatment involves stopping any offending drugs, correcting electrolytes, especially giving magnesium sulfate Fe, which is a specific treatment, and sometimes overdrive pacing to shorten the QT interval.
Wow, okay. Torsades, the twisting points.
Yeah.
And that leads us to the absolute most severe ventricular rhythm.
Indeed, ventricular fibrillation, or VF, this is the most frequent rhythm seen in sudden cardiac arrest in adults. It's characterized by rapid, completely disorganized, and ineffective quivering of the ventricles. The heart muscle fibers are contracting chaotically, not in unison, so the heart pumps no blood at all.
Just chaotic shaking.
Exactly. There's no cardiac output, no pulse. It is immediately fatal unless treated within minutes. On the ECG, you don't see any formed QRS complexes at all. It just looks like chaotic, irregular, undulating waves of varying amplitude. Sometimes it starts coarse, larger waves, and becomes fine, smaller waves, as the heart runs out of energy.
And the treatments.
Yeah.
Seconds count, right?
Absolutely. Immediate defibrillation is critical. That high-energy, unsynchronized shock is the only effective treatment to stop the chaos and give the heart a chance to restart with an organized rhythm. Every minute defibrillation is delayed, the chance of survival drops significantly. Defibrillation is always followed by high-quality CPR and advanced life support protocols, including medications like epinephrine and amiodarone. For patients who survive an episode of VF, an ICD is typically recommended for long-term prevention of recurrence.
Defibrillation, CPR, meds. Got it. And the final grim possibility.
That would be ventricular asystole. Asystole means no contraction. This is the complete absence of any detectable ventricular electrical activity. No QRS complexes, maybe just some occasional P waves if the atria are still trying, but essentially a flat line on the ECG, though you always check multiple leads to confirm it's not just a lead issue.
Flat line.
Yes. There is no ventricular contraction, no cardiac output, no pulse. Asystole is always fatal unless a specific reversible cause can be identified and treated immediately, like severe electrolyte imbalance or drug overdose, which is rare. Treatment involves immediate CPR and IV epinephrine, trying to stimulate any electrical activity. Defibrillation is not effective for asystole because there's no chaotic rhythm to shock. Unfortunately, the prognosis for asystole is extremely poor.
That's a sobering progression through the ventricular rhythms. Okay, let's move to our final major category of dysrhythmias, the atrioventricular AV blocks. These aren't rhythms originating in a specific spot, but rather problems with conduction, the electrical signal getting through from the atria down to the ventricles.
Exactly. These dysrhythmias involve a delay or intermittent or complete failure of the electrical impulse generated by the sinus node, or another atrial focus, to travel through the AV junction and activate the ventricles. Think of it like a faulty wiring connection or a persistent traffic jam in the heart's electrical highway, specifically around that AV node bundle of his area.
A communication breakdown.
Precisely. We classify AV blocks based on the severity of the conduction impairment. The mildest form is first-degree AV block. Here, every single atrial impulse does get conducted through the AV node to the ventricles, but it takes longer than normal. So on the ECG, you'll see a P wave followed by a QRS complex for every single beat, just like a normal sinus rhythm, but the PR interval is consistently prolonged greater than 0.20 seconds, or one large box on the ECG paper.
So just a consistent delay, but everything still gets through. Is that usually a problem?
Usually, no. First-degree AV block itself is often benign, especially if the QRS complex is narrow. It often doesn't cause any symptoms and typically requires no specific treatment. However, it's usually noted and monitored, as in some cases it could potentially progress to higher degrees of block, especially if associated with certain conditions or medications.
Okay, mild delay. What's next?
Next is second-degree AV block. This means that some atrial impulses fail to conduct to the ventricles while others get through. There are two main types, and distinguishing them is important because they have different implications and treatments. Second-degree AV block type I, also commonly known as Mobitz I or Wenckebach, pronounced Wenck-Ebach. The hallmark of this type is progressive lengthening of the PR interval over several consecutive beats until finally one P wave occurs that is not followed by a QRS complex. We say the beat is dropped. Then the cycle typically repeats, often with the PR interval after the dropped beat being the shortest.
So it gets longer.
Yeah.
Drop, like the signal's getting tired.
That's a great way to think about it. The conduction delay increases progressively until it fails completely for one beat. This type of block usually occurs within the AV node itself, is often transient, and can be caused by increased vagal tone, like in athletes or during sleep or certain medications. It's often considered relatively benign, especially if the QRS is narrow, and usually only requires treatment, like atropine, if the resulting pauses cause symptoms due to a slow ventricular rate.
Okay, Wenckebach. Progressive lengthening, then a drop beat. What's type 2?
Second-degree AV block type 2, or Mobitz 2. This one is generally more serious. Here, you have intermittently dropped beats, P waves, that are not followed by a QRS. But the key difference is that the PR interval of the conducted beats remains constant. There is no progressive lengthening before the dropped beat. It's like the conduction just suddenly fails without warning for one or more beats.
So PR is steady, 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 drop. Much more unpredictable.
Exactly. And importantly, type 2 block usually occurs below the level of the AV node in the bundle of his or the bundle branches. It's often associated with underlying structural heart disease and frequently occurs with a wide QRS complex. Why it matters. Mobitz 2 is less common than type 1, but it carries a much higher risk of progressing suddenly to complete AV block, third-degree block, which can be life-threatening. Because of this risk, Mobitz 2 often requires treatment with a permanent pacemaker, even if the patient isn't currently symptomatic. Atropine is generally not effective or recommended for type 2 block because the block is below the AV node.
Okay, type 2 is a more concerning one, often needing a pacemaker. Is there anything between type 2 and complete block?
Yes, sometimes you'll see the term high-grade atrioventricular block. This usually refers to a situation where two or more consecutive atrial impulses, P waves, are blocked for every one that gets through, example, a 3.1 or 4.1 block, or even more severe patterns. The ventricular rates tend to be quite slow and patients are often symptomatic. This is a serious condition often requiring pacing. It can sometimes be difficult to distinguish between a severe Mobitz 3 and Mobitz 2 in this situation.
And then the most severe form of block, the complete communication breakdown.
That's third-degree atrioventricular block, also known as complete heart block. In this situation, there is complete failure of conduction of any impulses from the atria to the ventricles. The atria and the ventricles are beating completely independently of each other. This is called AV dissociation. On the ECG, you'll see P waves occurring at their own regular rate, driven by the sinus node or another atrial focus, and QRS complexes occurring at their own, usually much slower, regular rate, driven by a backup escape pacemaker located below the level of the block. There is absolutely no relationship between the P waves and the QRS complexes. The PR intervals are completely variable because the chambers are dissociated.
So the top and bottom floors are just doing their own thing, totally out of sync.
Precisely. The location of the backup pacemaker determines the rate and QRS width. If the escape rhythm originates in the AV junction, above the bifurcation of the bundle branches, the rate might be 40-60 BPM and the QRS will be narrow. If the block is lower down, the escape rhythm has to come from the ventricles themselves, resulting in a very slow rate, 20-40 BPM, and a wide QRS complex. Third-degree AV block almost always causes significant symptoms due to the extremely slow ventricular rate, severe bradycardia, and loss of AV synchrony. It is a medical emergency, often requiring immediate temporary pacing, external or transvenous, followed by the implantation of a permanent pacemaker. Atropine is usually ineffective, especially if the QRS is wide.
Wow. Okay, that covers the spectrum of AV blocks from slight delay to complete dissociation.
Mhm.
So we've talked about all these different rhythms, many of which require intervention. Let's circle back to some of those crucial interventions. What happens when these rhythms become dangerous or life-threatening? We have some powerful tools, right?
Absolutely. When the heart's own electrical system falters badly, either going too slow or dangerously fast and chaotically, we have electrical therapies that can either provide the necessary stimulus or reset the whole system. The main ones are pacing, defibrillation, and cardioversion.
Let's start with pacing. When is that used?
Right, pacing, specifically temporary pacing in the acute setting, is primarily used when the heart rate is too slow, bradycardia, and causing significant symptoms like hypotension, confusion, chest pain, or shock, especially if medications like atropine haven't worked or aren't appropriate, like in type 2 or third-degree AV block. So its main job is to provide a reliable heartbeat when the heart's own pacemakers fail. Interestingly, pacing can also sometimes be used to terminate certain fast, regular rhythms, like some SVTs or atrial flutter, through a technique called overdrive pacing. You pace the heart slightly faster than the tachycardia for a short period, then abruptly stop, hoping the heart's natural pacemaker will take over at a normal rate.
So mainly for slow rates, sometimes to stop fast ones. How is temporary pacing actually done?
There are a few methods for temporary pacing. Transvenous pacing. This is probably the most common internal method. A special pacing wire, lead, is inserted into a large vein, like in the neck or groin, and advanced, usually under fluoroscopy X-ray guidance, until the tip rests inside the right ventricle. The other end is connected to an external pulse generator, the pacemaker box. Epicardial pacing. Pacing wires can be sewn lightly onto the surface, epicardium, of the heart, usually the atrium and/or ventricle during open heart surgery. These wires exit through the chest wall and can be connected to a pulse generator if pacing is needed postoperatively. They're usually removed before the patient goes home. External transcutaneous pacing. This is the fastest method for emergencies. Large electrode pads, similar to defibrillator pads, are placed on the patient's chest and back. These pads deliver an electrical stimulus through the skin and chest wall to capture the heart muscle. It can be quite uncomfortable or painful for the patient because it stimulates chest wall muscles too, so it's usually a bridge to getting transvenous pacing established if needed long term.
Okay, different ways to deliver the spark. What are the components of the pacing system? You mentioned the generator and the lead.
Yeah, the basic components are the pulse generator. That's the battery-powered box that creates the electrical impulses. It has controls to set the pacing rate, how many beats per minute, the stimulus strength or output, measured in milliamperes, MA, how strong the electrical jolt is, and the sensitivity, measured in millivolts, MV, how well the pacemaker can see the heart's own intrinsic beats. And the second component is the pacing lead, which is essentially an insulated wire that carries the electrical impulse from the generator to the heart muscle and also carries information about the heart's intrinsic activity back to the generator for sensing.
Okay, you mentioned output and sensitivity. Those sound like really important settings. Can you explain capture and sensing?
Definitely. These are two fundamental concepts in pacing. Capture refers to the successful depolarization of the heart chamber, atrium or ventricle, in response to the pacemaker's stimulus. On the ECG, you see the pacemaker spike immediately followed by the corresponding waveform, a P wave if pacing the atrium, or a wide QRS complex because it originates from the pacing lead tip if pacing the ventricle. To ensure capture, we need to set the output high enough to reliably stimulate the heart muscle. We usually find the minimum energy needed, the threshold, and then set the output slightly higher for a safety margin. If the output is too low, you'll see pacing spikes that aren't followed by a P wave or QRS that's failure to capture.
Got it. Output ensures the pacemaker makes the heartbeat. What about sensing?
Sensing is the pacemaker's ability to detect the heart's own intrinsic electrical activity, the patient's natural P waves or QRS complexes. This is crucial for pacemakers operating in demand mode, which is most common. A demand pacemaker should only fire if the patient's own heart rate falls below the set lower limit. If it senses an intrinsic beat, it should inhibit itself and not fire, preventing competition between the pacemaker and the heart's own rhythm. The sensitivity setting determines how sensitive the pacemaker is to detecting these intrinsic signals. It's measured in millivolts, MV. Now, this can be a bit confusing. A lower MV number on the sensitivity dial actually means the pacemaker is more sensitive. It can see smaller intrinsic signals. Think of it like lowering a fence. The MV setting makes it easier to see over it, detect smaller signals. If the sensitivity is set too low, number too high, fence too high, the pacemaker might not see the patient's own beats and fire inappropriately, failure to sense or undersensing. If it's set too high, number too low, fence too low, it might misinterpret electrical noise or small signals as real beats and fail to pace when needed, oversensing.
Lower number means more sensitive. Got that fence analogy, that helps. So demand pacing is standard. Is there ever a reason not to sense, like fixed rate pacing?
Asynchronous fixed-rate pacing, where the pacemaker fires at a set rate regardless of the heart's intrinsic activity, essentially sensing is turned off, is generally considered unsafe, especially for ventricular pacing. Why? Because if the pacemaker fires during the vulnerable period of ventricular repolarization, the T wave, it can potentially trigger ventricular fibrillation. So demand pacing, which respects the heart's own rhythm, is the standard of care. Asynchronous modes might be used very briefly in specific emergency situations or during testing, but not for ongoing pacing.
Okay, demand pacing is key. Now shifting gears to the more dramatic interventions, defibrillation versus synchronized cardioversion.
Yep.
They both involve delivering an electrical shock, but you mentioned earlier they're used differently. Can you break that down?
Absolutely. They sound similar, but the distinction is critical and based on the specific rhythm and whether the patient has a pulse. Defibrillation is used only for the most life-threatening pulseless arrhythmias, ventricular fibrillation, VF, and pulseless ventricular tachycardia, VT. In these rhythms, the heart is either quivering chaotically, VF, or beating so fast and inefficiently, pulseless VT, that there is no effective cardiac output. The goal of defibrillation is to deliver a high-energy, unsynchronized electrical shock across the heart. Unsynchronized means the machine delivers the shock as soon as the button is pressed, without regard to the heart's electrical cycle, because there's no organized cycle to sync with. The shock aims to depolarize essentially all the heart muscles simultaneously, stopping the chaotic electrical activity, like hitting a reset button. The hope is that the heart's natural pacemaker, usually the sinus node, will then take over and reestablish an organized, effective rhythm.
Okay, defib for VFs and pulseless VT. High energy, unsynchronized shock. Reset button. What about cardioversion?
Synchronized cardioversion is used for certain tachycardias, fast rhythms, where the patient still has a pulse but is hemodynamically unstable, low blood pressure, confusion, chest pain, signs of shock. Common rhythms treated with synchronized cardioversion include unstable supraventricular tachycardia, SVT, unstable atrial fibrillation, unstable atrial flutter, and unstable ventricular tachycardia, VT, with a pulse. The key difference here is the synchronization. The cardioversion machine is set to monitor the patient's ECG rhythm and deliver the electrical shock precisely timed to occur during the QRS complex, ventricular depolarization. It actively avoids firing during the T wave, ventricular repolarization.
Why is avoiding the T wave so important?
Delivering a shock during the T wave, which is the electrically vulnerable period of the ventricle, could actually induce ventricular fibrillation, the very rhythm we use defibrillation for. So synchronization is a critical safety feature when cardioverting someone who still has an organized rhythm and a pulse. The energy levels used for cardioversion are also often lower initially than those used for defibrillation, depending on the specific rhythm being treated.
Ah, that makes perfect sense. Syncing avoids hitting that vulnerable recovery period. So the key takeaway here is no pulse, VF pulseless VT, gets unsynchronized defibrillation. Pulse present but unstable tachycardia gets synchronized cardioversion. Timing and the specific rhythm are absolutely critical for choosing the right life-saving electrical intervention.
You've nailed it. That distinction is fundamental.
Wow. That was truly, truly a deep dive into the fascinating and incredibly complex world of cardiac rhythms. From those tiny electrical sparks kicking off in the sinus node, all the way to the powerful, dramatic interventions like pacing and defibrillation that can literally save a life. It's just clear how intricate and absolutely vital our heart's electrical system is.
It really is astonishing when you broke it down. And understanding these basic concepts, being able to look at those wiggly lines on an ECG and have some idea of what they mean, or knowing the serious implications of a rhythm like atrial fibrillation, especially its crucial link to stroke, it really empowers you with critical knowledge, whether it's about your own health or the health of people you care for.
Yeah, definitely. Whether you're a healthcare professional tuning in, or maybe just a curious learner, or someone who simply wants to understand their own body a bit better, we really hope this deep dive gave you some truly insightful aha moments today.
And perhaps it leaves you with this thought to ponder. When you consider just how precisely coordinated every single beat of your heart needs to be, second by second, minute by minute, for your entire life, doesn't it just make you wonder about the incredible, intricate balance required for every single system in your body to function so seamlessly? What other unseen electrical orchestras are playing within you right now, keeping everything else in perfect sync?
That's a fantastic thought to end on. Until next time, keep exploring, keep learning, and keep asking those deep questions.